I'll sometimes use gavel, sometimes I don't. um, Any case, 10 o'clock, I want to start right on time, a little bit after 10, which is, that's okay, but we're going to be more timely next time. But first of all, this is the first meeting of the Budget Review Subcommittee on Health and Family Services. I really appreciate everybody coming out and participating and listening to what we think is going to be a good robust conversation from here for the next couple of weeks when it comes to Medicaid. With that, is there the members have any guests or they want to introduce? Go ahead, Representative.
Thank you, Mr. Chairman. I think, well, this is Psychology Day at the Capitol, and I think there may be some members of the Kentucky Psychological Association here, as well as some psychology graduate students, and we know how desperately we need you in the state right now, and thank you for being here and for being in the room with us today.
Very good. All right. Thank you, Representative Willner. Let's see. All the information that is going to be presented today should be online, so feel free to download that at a later time if you have not already. And Ben, would you mind taking the roll?
Representative Duval.
Here.
Representative Johnson.
Here.
Representative Raymer. Representative Willner. Here. Representative Wilson. Representative Bowling. Representative Bray. Representative Heverin. Representative Moser, Representative Petrie, Representative Williams.
Here.
Chair Fleming.
Present. All righty. Let's see. We have two individuals from DMS, Department of Medical Services, and I just want to remind you all, if you don't mind, we use a lot of acronyms, DMS, CMS, whatever. Sometimes I get SICK, so if you don't mind, just go ahead and spell out or say the name of the acronym that you're thinking of. So that sort of helps out, at least keeps me straight and so forth. So we have Commissioner Lee and Mr. Bechtel with us today. So if you don't mind, go ahead and identify yourselves, and you got the floor. Yep, there you go.
Good morning. I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services, and I'm also the current President of the National Association of Medicaid Directors.
Steve Bechtel. I'm the Chief Financial Officer for the Department for Medicaid Services.
Very happy to be here today to give you an overview of Medicaid and some of the services that we're providing in the realm of behavioral health and substance use disorder treatments. This first slide just gives you an overview of the Medicaid program in general. Today, the Medicaid program serves approximately 1.4 million Medicaid members throughout the state. Over half of the children in Kentucky are served by the Medicaid program or the Kentucky Children's Health Insurance Program. Currently, the state has a little over 1.1 million children in the state, and over 600,000 of those children live at or below the poverty level and therefore are enrolled in Medicaid and the Children's Health Insurance Program. We have 485,000 expansion members. These are members who are between the ages of 18 and 65 and who live at or below 138% of the federal poverty level. And we have over 69,000 enrolled providers who treat and provide care to our Medicaid members. In state fiscal year 2024, our total budget or expenditures was $18.5 billion. That includes both medical services and administrative costs. This just gives you a description, overview of behavioral health services and Medicaid. This is a slide from the Kaiser Family Foundation that shows of all the state's Medicaid agencies, the number of services that each state covers. You can see Kentucky is within the 44 to 47 services range. That includes an additional 13 states. There are 11 states that cover 48 or more behavioral health services. Some of the services, this is not an all-inclusive list, and I don't think I'll need to read all of this to you, but these are just some of the services that the Medicaid program provides, such as screenings, assessments, lots of different, both inpatient, outpatient services to treat behavioral health services and substance use disorders. I just wanted to give you a little depiction of the total number of behavioral health providers that are enrolled within the Medicaid program. You can see in 2019 we had a little over 4,500 providers who were delivering behavioral health and substance use disorder services. Fast forward to 2024 and we have almost 8,000 providers delivering services specifically to behavioral health. This just gives you a little bit of a number that the growth in the providers who have enrolled and who have been treating behavioral health services from 2019 to 2024. So you can see, for example, almost in the middle, licensed professional clinical counselors. We have 1,308 providers enrolled in 2019, and we now have 2,141. So to get to this spend for Medicaid behavioral health services, we do look at our claims that are submitted by providers. We have Medicaid fee-for-service claims. Fee-for-service is our population that is enrolled in or that is in a long-term care facility, or they are receiving services through a home and community-based waiver. Those are services designed to keep individuals in their home rather than in a facility. And so the fee-for-service population, providers submit claims directly to the department for reimbursement. However, 90% of the Medicaid membership is served by Medicaid Managed Care Organizations, or MCOs. So we have encounter data because Medicaid itself does not pay those claims. We pay the managed care organizations per member per month capitation payment. And out of those capitation payments, they have to deliver all of the services to our Medicaid members, including behavioral health and substance use disorder services. So in order to get to the spend for behavioral health, we looked at both Medicaid claims and encounter data. We pulled claims based on codes that are on our behavioral health fee schedule. We also looked at claims that may have had, for example, an evaluation and management code with a diagnosis of a behavioral health, so that we could make sure that we were capturing everything that we wanted to look at. And we looked at services based on a paid date of service. And as we go forward, we're going to show some expenditures and some procedures. And because managed care organizations cover about 90% of our population, it was easier to just focus on those numbers. We do have some fee-for-service numbers in here too. But as you can see from this slide, the Medicaid members utilizing behavioral health services in the MCO population, again, that's 90% of the Medicaid members. You can see that there were 421,483 individuals in 2023 utilizing behavioral health services, and 426,000 in 24. And the chart on the bottom just shows the fee-for-service members. As you can see, 32,000. So it was a little bit definitely smaller than the MCO population. And again, when we look at claims, a claim that is submitted to the department can have several diagnosis codes on it. So with those claims with just a primary diagnosis code of behavioral health or substance use, you can see that we had the total numbers there. So those numbers that we're showing also received a substance use disorder service could also be included in those total members with behavioral health service. And the more diagnosis codes that you go down, for example, on a claim form, if you look at primary, secondary, third, fourth diagnosis codes, the more members you may pull up. That's why the numbers are higher in that secondary diagnosis code. Now, of those individuals, these are MCO top procedure codes. I apologize that the procedure code doesn't have the description in the chart. It was a little bit difficult to get on there, but we did put the description over to the left for your review. So you can see, for example, in 2023 for age 18 and under, and we always like to break out children from adults because children are just a little bit different in their plans of care. So you can see that the top code was definitely 99213. If you look over on the procedure code description, you'll see that code is an evaluation and management code. And then you can see the total dollar amounts paid by each procedure code. Again, same information except for 2024. You may see a little bit of a difference in the procedure codes that were billed. And again, these are just the top procedure codes. These are not. This does not include every single procedure code, and the amount paid does not include the total that we have spent during the year. The total spend on behavioral health services for MCOs only, as you can see in 2023, was a little over $2 billion. In 2024, $2.3 billion. And we do have this broken out by all of the MCOs. You can see that WellCare has the most expenditures. They also have the largest membership of the managed care enrollees, with Molina being second. And again, they have pretty large membership. This is a spend by provider type. And again, this is not every single provider that had billed a procedure code. These are just some of the top procedures or the top providers that we wanted to show, and it is sorted by the largest amount in 2024. So you can see some of the trend in behavioral health spend by provider type as we go forward.
Commissioner,
yes.
I'm sorry to interrupt you. Just for clarification, if you go back to the previous slide, you have the total spend by MCO. Is this last year's number for Anthem?
Yes, this is last
no
year's.
longer that? No
Yes.
longer.
As of January 1st, 2025, Anthem is no longer a Medicaid managed care organization. So their membership was divided out between two of the other MCOs. So as we go forward, as we track these numbers, you will see that Anthem will no longer be in here for a while. They will have some claims run out, but not near the level that they have in this slide.
And the reason they're no longer a provider?
There was a court order or a litigation that ended with them no longer being a managed care organization.
Yeah. Thank you.
So as we talk about substance use disorder, those, again, the behavioral health claims and the total spend does include the substance use disorder services. Again, we just wanted to show some of the spend. So for example, in 2024, of the $2.3 billion that was spent on behavioral health services, a little over $1 billion of that was spent specifically on substance use disorder. We did list the number of individuals who are receiving substance use disorder services based on per month. There's residential. You can see the average number of beneficiaries receiving Medicaid-assisted treatment has dropped slightly from 2023 to in 2024, a little over 1,000 less. We do have the average number of emergency department visits per 1,000 beneficiaries. Again, that kind of is remaining a little bit steady, as is the number of inpatient stays for substance use disorder per 1,000 beneficiaries. The number of overdose deaths, as you can see, has dropped from in 2023. It dropped from 1,634 to 1,317. We think this is very significant because the services that Medicaid is providing to the individuals who are enrolled in Medicaid and who need these services are helping. We are taking care of a large part of the population. Medicaid is the largest payer of behavioral health services in the state, including substance use disorder treatment. So it's very, very necessary for the population that we serve in order to help them lead their best lives. Just some trends, again, that we are seeing in the behavioral health arena. As you can see, members receiving substance use disorder treatment is dropped slightly. However, members receiving residential treatment per month has increased a little bit. The number of members receiving Medicaid-assisted treatment has decreased, and reduction in overall deaths is 19% for substance use-related disorders. And with that, I'd be happy to entertain any questions or comments.
Thank you very much, Commissioner. I wanted to, first of all, thank you for coming in. I know some of these slides are repeat from the presentation you made back in December, but there's some good other information we can go through and dissect that and so forth. I just want to ask just a couple of general questions. And looking at the CPT codes that you sent, and thank you very much to the staff for bringing that to me. One thing that sort of came up to me, and that is, in particular, one of this under the substance use and disorder. It's code H0038 peer-to-peer. and so forth, and that seemed to be significantly increased that I can see. In fact, when you made a presentation, it went from 2021 of 2 million. Now we're looking at annualized of 2023, and I think it's much higher than that. Of $4 million is at one point, well, it was 104 million, 104% increase. Could you explain or give some rationale or thoughts behind how that significantly increased, and what controls do you have in order to monitor that?
Certainly. So in 2023, the Department for Medicaid Services had two distinct behavioral health fee schedule. One was for facilities and one was non-facilities. And a decision was made based on recommendations from our technical advisory committee and behavioral health providers to combine those fee schedules. So when we combined those fee schedules, we looked at the reimbursement rate for each of those codes, and we did not want any provider to receive a reduction in reimbursement, so we chose the higher reimbursement rate when we combined those fee schedules. We have noticed an uptick in the peer-to-peer services. We are continuing to monitor that. And as of January 1st, 2025, we did put out a letter. As you know, we have not had prior authorizations on many of our services for some time since COVID. So in I think it was October, early November, we mailed a letter to all behavioral health providers. We are looking at peer-to-peer supports. We are looking at limiting some of the services or the number of services that they can bill, and a few other things. So we are putting some controls around that. We are also exploring some prior authorizations around some of our behavioral health services. So we will continue to monitor and make sure that all of those services are being delivered appropriately and in the best interest of our members based on their plan of care.
So you sound like you have some type of a little bit of an oversight in order to monitor that. And
Yes.
okay, and I appreciate if you could, I guess maybe down the road, and I'll use that loosely, if you can report on exactly how that's going, because like I said, that sort of came out to me. There's a couple other ones, 97 135. That was 132%, from 500,000 up to 1.2. That's a pretty significant increase. I guess my overall concern and thought about this is that making sure we have some oversight, make sure there's some controls, and looking at, and also what type of utilization review are y'all doing in order to make sure that things are held under a more of a controlled manner, making sure there's nothing overutilized.
And so what we plan to do, and based some of the information in here you said has been repeated, but some of it is fairly new. And when you look at it year over year, you start seeing those trends. So what we are going to do is develop a behavioral health report that is generated in exactly the same manner, because when you pull information from Medicaid claims data, there's a variety of ways that you can pull it. You can pull it based on paid date. You can pull it based on date of service. There's all kinds of parameters that you can put around those. So what we want to do is design one specific report that is generated the same way each month, so that we can monitor utilization trends, and if necessary, insert some controls, or just continue to monitor and make sure that all of the services, again, are being delivered in a manner that is in the best interest of our patients, and that the providers understand billing requirements and those sorts of things as we go forward.
Okay. Representative Johnson, you have the floor.
Thank you, Mr. Chairman. And so I'm new to this committee, so I'm going to be asking some basic questions. I'm going way back to like the first or second slide. One of the statistics that you showed was the number of providers that you have, and it looked like it had almost doubled in the last few years. Is that, I guess I don't understand how it could rise that quickly. And then a corresponding question is there a corresponding number of clients or patients served that goes with that increase in providers? I'm just trying to understand how that happened.
So, and I think going way back to I've worked in Medicaid over 20 years, and going way back to 2014. we, the department, did not typically cover all of these behavioral health services. And so when we began covering behavioral health services in 2014, we opened up the provider enrollment. We opened up the number and types, actually the type of provider that could enroll in the department. For example, we used to not cover licensed marriage and family counselors or licensed professional clinical counselors, or a lot listed on this this spreadsheet here. So as the program has continued to evolve, we have gotten several providers who want to enroll and deliver services. Behavioral health services in the Department for Medicaid Services account about a little over 30% of our population have behavioral health needs. So as the demand for those behavioral health services has grown within the population, so has our provider enrollment.
So is it fair to say that it's not that there's been this doubling of a need? It's been more of what your scope of responsibilities are as brought those into your tent?
That is correct. I mean, there is a need. I mean, we do see an increased need. Particularly after COVID, we have seen an increase in the need for behavioral health services for children, and we have seen an increase in substance use disorder treatment needs, for example. So while there has been a slight increase in the need year over year, the provider enrollment trends have kept up with those needs. But given that Medicaid will turn 60 this year, the Medicaid program will be 60 years old this year, and given that we just started covering behavioral health services in 2014, so about 10 years, we're going to see these trends continually, and that's why we want to definitely have that behavioral health report to show those trends that's created on a routine basis with the same exact information, so that we can develop interventions as necessary as we move forward.
So that chart showed pretty much a straight line increase. Is that the new reality? Are we going to continue to see that kind of an increase, or are we looking at some point where we're going to level off?
We're going to continue to monitor that trend to see if at some point we may level off.
Okay. Thank you, Mr. Chairman. Thank you.
Sir. Representative Wilner.
Thank you, Mr. Chairman. Thank you for the report. Always appreciate hearing from you guys. I guess similar question, but I guess more from the provider perspective. Sometimes I hear, a lot, I hear from providers, we would love to offer Medicaid services in my practice, but the reimbursements are just not sustainable. You know, it takes hours, days to do a full psychological assessment, and then the reimbursement rate is so low. So I guess my question is, and I know you touched on reimbursement rates and choosing the higher, which is great, but I would love to hear sort of the trend on what reimbursements to providers have been, and also if you are attracting, retaining, enrolling sufficient numbers to meet the needs.
Currently, I don't have the trends on the reimbursement. We can definitely get those to you. But based on the trend and the number of providers that are enrolling, as you can see, it's almost doubled. We do believe that we have enough providers to meet the need. Would caveat that with, there have been several studies that show, for example, that adults have better access to behavioral health services in Kentucky than children. So if we focused on one area, it would be for those behavioral health services specifically for children.
Just to clarify, Commissioner, did you say you have enough providers to meet the need?
We based on the number of providers that enrolled and the number of individuals that are seeking behavioral health needs, and our managed care organizations that serve 90% of our population are required to ensure that every individual in the program has access to and care to the services that they need. So as of right now, the trends that we're looking at and the MCO access to care indicates that individuals do have access to behavioral health services.
Okay, I appreciate that, but I have to respectfully disagree with that. I just don't think the need is the providers aren't there, because that's a whole nother conversation and issue in terms of workforce. But the need is there. I mean, it's significant. So, in any case, but I appreciate that. Let's see, Representative Williams.
Thank you, Mr. Chair. Thank you all for coming today. I appreciate your input and the data. As the new vice chair, here. There's a couple of things that I wanted to dive into, kind of to get myself up to speed. And one, obviously, is health outcomes and what does that look like for the state of Kentucky. And number two is obviously the budget part of that. Can we pay for these continued services, and will it break the bank over a long period of time? So with that in mind, I'm kind of looking at everything, when I'm trying to evaluate these things. And when you talked a little bit earlier about some expanded services, one thing that kind of stood out to me, and it maybe I'm misunderstanding it, but I saw in some of the data that MCOs were paying for non-emergent transportation. And it took, you correct me if I'm wrong, but I was thinking that may have been carved out or that may be subject to a different set of rules. But I think if I'm seeing the data correctly, it's like $54 million we paid out for that. Can you kind of explain that and how that works? And is that a expenditure that we can expect to continue this as we move along?
So currently, non-emergency medical transportation is a capitated arrangement. It is not with the managed care organizations, but we do contract with the Office of Transportation Delivery in the Department for Transportation, or the Transportation Cabinet. The way that works is we pay a capitated per member per month for every single member. The Office of Transportation Delivery administers that benefit. The Office of Transportation Delivery, contract with various brokers throughout the state, and they contract based on requests for proposals that they do on a routine basis. Office of Transportation Delivery contracts with the brokers, and the brokers enroll providers, actual transportation providers, to deliver those services to Medicaid members throughout the state.
Okay. There's some specific coding questions that I saw, and I hate to just throw these random codes at you, but I don't know if you may have them handy or not. I try to look at the largest increases and where, if you can save or dial in some of these, we can probably squeeze a lot more out of our dollars. Specifically, S5 108, T1019, and T2040, and gosh, I apologize, I can't read my first handwriting. 7535. I want to say it's
probably a 9.
9.
Usually they're 9.
97535. The reason that I bring these up, we're looking at like $869 million. I don't expect you to know this today, but if you could just maybe report back to me on these codes and maybe the circumstances around them, and again, back to the point about controls in place that you have, that you monitor those. If you wouldn't mind, get that back to me, that'd be great.
Certainly would do that.
Thank you. That's all I got. Sure.
Thank you, Vice Chair. Commissioner, I just want to go back to what you said in terms of when you're explaining the non-transportation of y'all contract with the transportation, and they contract with the brokers, and then they go out and contract. To me, that seems like if I produce a widget, I go to a wholesaler and they they send that out, and they send out the retail, and they go do something else. That seems like a lot of layers, and we're paying this particular rate. Which I imagine you've gone through an actuarial or some type of a cost analysis in doing that. So, to me, there's a lot of layers in there, and it seems like there might, I don't know. To me, it's a lot. It could be a lot of markup, whatever. I don't know. I guess I'm trying to figure out how you determine your rate in order to go through that, given all the layers that are in there. It seems like it could be a bedded cost increase where you can basically go and basically go right to the broker or right to the providers and provide that and look at saving some money, or better yet, providing better quality of service.
would be more than happy to come back and provide a report on the non-emergency medical transportation benefit and how that is administered, and the trips. For example, the Office of Transportation Delivery and the brokers provide over 2 million trips per year, and there's a lot that goes into the transportation benefit. For example, cars have to be inspected, all of the drivers have to go through a background check. Vehicles also have to have accommodations for individuals who are wheelchair bound, or just making sure that individuals have the right mode of transportation for them. Some of the transportation is included in bus passes, for example. We may have a certain population that is more mobile and they live in an urban area, and they will get a bus pass to go to their medical transportation visits. And every non-emergency medical transportation trip has to coincide with a medical visit on that same day. We do have checks and balances to make sure that all of the trips that are delivered in our non-emergency medical transportation program have a corresponding medical visit on the exact same day.
And that's $1.5 million that y'all provide the transportation from them to go through and monitor all that? Or is that just basically,
Yeah.
yeah.
Yeah,
Is that what that is?
the Office of Transportation Delivery administers and monitors all of that to make sure all of those processes to make sure that the cars are inspected and they have tags and they have all of their insurance, and that the drivers themselves pass background checks, because there is a huge safety issue in transporting anyone, and in addition to the Medicaid members.
Okay. Representative Johnson?
Thank you, Mr. Chairman, again. I was prompted by your question about reimbursement rates, and I'm trying to understand a little bit of the history of where we are as far as rates are at this point. If I'm correct, didn't we do basically a rate evaluation a few years ago? And I think I'm dealing mainly in my mind. I'm dealing with SCLs at this point.
A few years ago, we did do a rate study. Based on home and community-based waivers, those 1915C home and community-based waivers. We did a specific rate study for that particular provider group. It was not broad and encompassing of the whole entire Medicaid provider base.
So, and my understanding is that based upon that study, last year in our budget, the 2024 budget, we effectively allocated funds to reimburse providers at the 100% rate.
We based on the budget, we recommended a 70% increase. Now, one of the reasons to do that rate study is we have 6 home and community-based waivers, and there was some misalignment between reimbursement for the same procedure, across. For example, one was targeted case management. So what we wanted to do was align all of those rates so that each waiver was receiving the same amount of reimbursement across the service delivery system. So what we found, there were some providers who are receiving above, some rates that are receiving above 100% of the recommended rate. So we recommended 70% to bring everyone up to that level. If individuals were making above 100% of the rate study, we did not reduce their reimbursement. Again, we did not want to penalize any provider. So there are some rates that are above 100% right now, and some are at 70% of the recommended rate. And again, that was based on budgetary issues and concerns. And Steve, do you want to add anything to it?
I'll just say that the rate study that was done was what was in the budget, like you said, was about the 70th percentile of that rate study. However, by doing what the commissioner said, we're actually funded around the 82% of the study, because we did not decrease those rates. When you look at the rate study, some rates increased and some decreased, but we did not decrease those rates because we wanted to make sure, because we had a provider shortage, right, across the state, and we wanted to make sure that we did not deter the services for those individuals.
All right, so I'm trying to keep this at my level, which is pretty low. So the General Assembly budgeted for 100% based upon the rate study.
They did not.
We did not.
No. what we recommended was, what we put in our budget request was the 70th percentile of the budget, of the rate study. And that's what was funded.
Okay. I think we need an office visit. I need to understand this
Okay.
better. And I don't want to take the committee's time up, Mr. Chairman. I appreciate your leniency, but I've just got to get smarter on this. So if you would just make it a point, if we can try to get on each other's calendars, and sometime in the near future while we're here, while we're
Okay.
all in town, I would appreciate it, because I just don't, the numbers don't jive in my head, and I just need to understand better.
Medicaid is a very complex program, and I've been working in it 20 years, and I learn something new every single day.
Yeah, I went on Amazon and looked for Medicaid for Dummies, the book.
It
I
doesn't
haven't found it
exist.
yet, so
Happy to meet with you,
we'll
Representative
meet.
Johnson. Thank you.
Thank you for your leeway, Mr. Chairman.
No problem. And to our registered nurse, Representative Raymer.
Thank you. I'm sorry to go back to transportation, but I just want to clarify something, and I may have misunderstood you. Did you say you pay a fee for every member to the transportation?
The non-emergency medical transportation benefit functions very similar to a managed care organization where we have a capitation arrangement, and we do pay a capitation, and it's not to the level of a managed care organization that provides medical benefits, and all of those rates do have to be actuarially sound. And so we do pay that capitation payment, and out of that capitation payment, all of the non-emergency transportation services are delivered.
So I'm just wondering, and I would like to see how many out of the ones you were paying for, how many are utilizing the service? Because I know I've encountered a lot of people over the years that weren't even aware that they had transportation benefits. So it just seems like, should we just be paying for the service when they get it? And I thank the vice chair for bringing that issue up, because I didn't realize we were spending that much on non-emergent transportation.
We'll be more than happy to get you the report. The Office of Transportation Delivery does send a report on a routine basis. We have quarterly and annual reports. I can provide the annual report, and it does show the number of individuals, the percent of Medicaid members who are accessing those services. And there is a process, and every individual has to call the broker. The broker also has to determine that that individual is eligible on that date of service. But we'd be more than happy to get that report to you, Representative Raymer.
I've set those trips up for patients, so yes, I know. But thank you.
If I could just add on to that, on the NEMT, we do have a contract with our actuarial company, Milliman, and Milliman does an actuary study on the trips. So every year when we build that rate that you're talking about, we look at the utilization and then and the cost of that utilization, and we divide it out by the number of individuals in Medicaid to come up with that PMPM amount. So in a sense, we are using the utilization and are paying just for the utilization, but like you said, there could be some that's not utilizing that.
Okay. Anybody else? No. I want to shift gears, if you don't mind. I want to just talk a little bit about fraud, abuse, and so forth. How do you detect? How do you go about the process to look at any type of abuse in the system, and trying to resolve any type of fraudulent activities? How do y'all make sure that you all don't make sure that MCOs don't target individuals for whatever reason? How do you manage the complaints in those regards?
So we do have, as far as fraud, waste, and abuse, we do have a process and a system in place to monitor trends. We also work with various federal agencies, and I don't have all of those processes with me, but we do have a specific division within the Department for Medicaid Services that handles fraud, waste, and abuse. As far as the complaints from from providers, from members related to managed care organizations, we do have a complaint and grievance process that we monitor the complaints coming in. We do research and look at every complaint to make sure it's legitimate. We meet with the managed care organizations on a routine basis to bring up any issues, concerns that we're seeing or trends based on complaints. Again, we have a specific area that deals with complaints. They have developed a reporting process and monitoring process to look at every complaint that comes in and associate it with the specific MCO, the type of complaint that comes in, so that we can monitor and evaluate and again address any of those concerns with the managed care organizations as they come up.
So you say you do a lot of monitoring and so forth. What does that mean? I mean, I can say I monitor all kind of stuff, but that mean we don't do anything. What type of proactive approach? What type of mechanisms or measurements do you have to say, hey, something doesn't look right? We're seeing a jack up in a particular code for whatever reason. I mean, I can pick a couple of them that's like really scratching my head on. There's something going on here.
Yeah.
So what in particular are y'all doing, and how are y'all addressing it? And do y'all work with the Attorney General in order to resolve these?
Our Division of Program Integrity does work with the office or the Attorney General's office on a routine basis on these claims and or on any fraud and abuse allegations. And for example, you mentioned codes. When we see an uptick in codes, such as the peer support, that is when we wrote a letter to providers, but we didn't just sit down and say, hey, we're going to do this. We pulled in provider organizations and the managed care organizations and interested partners to say, hey, we're seeing this trend. Here's what we're going to do. We want your input. Does this seem reasonable? And we drafted a letter based on input from our provider community and our MCOs that put some parameters specifically around 2 or 3 codes that we noticed an uptick in utilization. So it's not that we just monitor and say, oh, here's an issue. We do actually take action when we see that there is a problem. Likewise, with the managed care organizations, if we see an uptick, for example, in audits, we will get information to make sure that the audit was appropriate, that there was a reason for the audit to take place, and we will, if we find an issue, we feel like, hey, this really isn't something you should be doing, we will take that back to the specific managed care organization and talk to them. Our contract has specific language laid out about what the MCO's responsibilities are, what they can, what they cannot do. And if there is an issue, a specific issue that is egregious, we can assess penalties on the MCOs.
Just define egregious. Hard time with that word. Define. I mean, I know what it means in my mind, but
If the MCO is doing anything that blatantly violates their contract, that is against either a federal or state regulations, laws. Again, there are other reasons that we can assess penalties, but we do continue to monitor and hold the MCOs accountable for all of the contractual obligations that they are required to adhere to.
okay.
And I'll just add on to how we identify fraud and abuse. It's like Commissioner said, it's within the program program integrity division that does it. But they have various algorithms that they run daily, weekly, monthly over all of our data to try to look at our encounter data, which comes in from the MCOs, or our claim data through the fee-for-service, and they kind of identify those anomalies. And then that may result in a desk audit or some type of other audit that they do with those providers. I believe it would, Jennifer Dudensky, who is the director over that division, she would be able to lay that out a little bit more in detail for you all if you desire to.
Do you have a best practice model on various functions that y'all provide?
Yes, we do have standard operating and procedures, and that would include some best practices, but I don't have all of that information with me at this time, but more than happy to get that back to you.
Okay.
And sometimes, when something's new like behavioral health to us, it's just been new since 2014, and we're seeing anomalies. That evolves some best practices moving forward. So basically lessons learned type of situations.
Okay. What's y'all's top 5 functions and mission of the DM or Department of Medicaid Services? What's your 5 functions? What's your mission?
Our main mission is to provide access to health care to those individuals who qualify for the Medicaid program. So that's our number one, is to provide health care, access to health care. Number two, and I haven't sat and wrote these out and looked, but the other thing that we have an obligation to do is to ensure that we're operating the program in compliance with all state and federal regulations and policies. We have obligation to ensure that only those individuals who qualify for the program are enrolled in the program. We also have a fiduciary responsibility to make sure that the funding that we receive is spent in accordance with all, again, federal and state regulations. And we have a commitment to the Commonwealth to operate this program efficiently and effectively so that this program will be in place for all of those who need that in years to come.
Okay, thank you. Any other questions for the members? Okay, Commissioner Steve, thank you very much for coming in. I would like to invite you next week, if you don't mind, and I will let you know what we're looking at. I'll talk with staff in terms of send you the topic as far as the next Wednesday at 10 o'clock. Let's see if there's not any other questions that y'all might have. We are going to meet on the 19th? Mm-hmm. The 19th. February, and I assume we'll be in this room at 10 o'clock. And so without any other comments, motion to adjourn? I'll make the motion. So moved. All right, we stand adjourned. Thank you all very much.